Hello everyone, my name is Jen Nolan and during National Pain Week, Musculoskeletal Australia is pleased to welcome you to our webinar this evening on the diagnosis and management of low back pain in primary care. We are pleased to be profiling this important topic during National Pain Week, given yesterday's release of the AIHW's updated compendium on chronic conditions, which indicates that 1 in 6 Australians reported back problems during 2014-15, and back problems were the third leading cause of disease burden in Australia in 2011. In addition to tonight's webinar, Musculoskeletal Australia has some great webinars for the remainder of the year, as you can see by the list on your screens now. You can purchase the webinars individually or as a series, and the recordings of previous webinars are available for purchase at any time. Before introducing our presenter for this evening, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on your screen. You can type a message at any time that will be read by the webinar organiser at Redback Conferencing. If you're listening via the phone, you'll notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will answer questions after the completion of his presentation, you can type questions for him at any time. Can I suggest you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m, Australian Eastern Standard Time. I would also be very grateful to all participants if you could take a moment during the question time in the webinar to respond to our feedback questions. Our presenter for this evening will be Dr Adrian Traeger. Adrian is a physiotherapist and an NHMRC Early Career Research Fellow. He has a special interest in primary care management of musculoskeletal conditions and has worked in primary care for 10 years before completing a PhD in medicine from the University of New South Wales. He has published 29 papers relating to low back pain and patient communication in leading peer-reviewed journals. Adrian's current research focus is on investigating strategies to reduce unnecessary imaging of low back pain. He holds a research-focused role at the School of Public Health, University of Sydney, and teaches in the medical program at Sydney Medical School. Without further ado, I'll hand proceedings over to Adrian. Thanks very much, Adrian.
Thank you, Jen, and thanks for the introduction. G'day everyone, and thanks for joining in this webinar. I'm very privileged to be giving it, and I hear that there are people from all over Australia tuning in, hopefully, so I hope to make this as interesting as possible for the clinical audience. I'm hoping my background in the clinical world, although I'm very research focused now, I've tried to keep the talk as clinical as possible. So yeah, we may as well get straight into it. So a little bit more about me. Jen gave a great introduction, but I wanted to give you a bit more of a picture of who I am. So I have a health and sports science background. I worked in private practice for 10 years before completing my PhD, and now I do. I gave up the clinical practice just last year to focus fully on my research, and my research area is on primary care, but also this issue of overdiagnosis and overtreatment. So I'm part of a research collaboration called the Wiser Healthcare Research Collaboration, and that is a group that's focused on problems with too much medicine. So doing too much for different conditions that spans cancer and women's health and men's health, and major public health issues where there are problems with just doing too much imaging, too much diagnostic testing, too many interventions. So I'm sort of leading that research in my research group in the Institute for Musculoskeletal Health, and this is based at Sydney Uni. We're in the King George V building, which is a beautiful old Art Deco building that's attached to the Royal Prince Alfred Hospital. This building, this image in the bottom right of this slide is where I'm coming to you from now. Actually, that office there is where I'm based. And yeah, as I said, the group that I'm part of is called the Institute for Musculoskeletal Health. So this is something that you wouldn't have heard of because we've only just introduced the name about a week ago and it's been approved from the university. So this is a collaboration between Sydney University and the Sydney Local Health District. So we're a group that was formerly part of the George Institute in Sydney, and now we're pursuing research as part of the School of Public Health. And the group is led by Chris Marr, which many of you will be familiar with. And it's a group of 50 wonderful researchers who have in some way contributed to this work, so I wanted to acknowledge them straight up. Yeah, but let's get on to it, because we've got a lot to talk about in the next 40 minutes or so, and then I want to leave some time for you to provide feedback and ask any questions that you might have. This is the outline of the talk for this evening, so I'm going to spend a little bit of time talking about the background to low back pain. I'll give you a couple of typical case studies, and then I'll go through the diagnosis and management. So let's start with just defining what I'm talking about when I say low back pain. So in the research world, we call low back pain any pain that's between the 12th rib and the buttock crease. And this is the definition that's used in the global burden of disease studies. So these are large epidemiological studies that try to track the prevalence of this problem around the world. And as many of you would know, and as Jen alluded to in her introduction, it's a very common problem. And it's one reason why we're so interested in it. So the prevalence in Australia, lifetime prevalence is 79.2%. So what that number means is that 80% of Australians at some point in their life will experience low back pain, which is a massive number. So pretty much everyone experiences it. The mean lifetime prevalence globally is a little bit lower. So when you put all the estimates from all over the globe, the lifetime prevalence is closer to about 40%. And that's because some of the estimates in some countries, such as Nepal, were a bit lower than places like Australia. But there's a large standard deviation on that estimate, which means it varies a lot around the globe, but really what we can say is that it's a very common problem. This is another figure at the bottom of this slide to give you an idea of how common back pain is. In 2015, 540 million people were affected by activity-limiting low back pain at any one time. So it's a ginormous problem, and none of us are going to be out of the job anytime soon if you're clinicians who see low back pain, or researchers like me now who study it. So this is another slide from the Global Burden of Disease study. So that's a massive worldwide study that tracked the impact of different conditions on years lived with disabilities. So on this slide, these are the conditions that cause the most years lived with disability. So this is the YLDs. And you'll see that in 1990, the leading cause of years lived with disability was low back and neck pain. And still in 2015, it's the leading cause. So it causes more disability, causes more years lived with disability than things such as diabetes, depression, osteoarthritis, and COPD. Very burdensome problem. In terms of what causes it, it's obviously a very complex problem. We know there are nociceptive factors that could be happening in the tissues, but they're neither sufficient nor necessary to cause pain. Pain is the result of a multitude of factors that emerge as part of the pain experience. So it's ultimately a brain thing. And nociception is often part of it, but there's going to be factors related to general health, a person's social situation, what they're thinking and feeling at the time, and other complex genetic factors could all interact with nociceptive input or nerve signals coming from tissues in the back to produce the pain experience. And this figure was taken from the latest Lancet series on low back pain, and really it's just to demonstrate the complexity of what causes low back pain, and it's often never going to be one thing can explain how much pain someone experiences. No one thing could do that. It's just too complex. So that's the background to the condition that I'm going to be talking about. Now I just wanted to go through a couple of typical case studies that might present to primary care, which is where my experience lies and where most of my research is focused on. So the first case study is someone who might present to a physiotherapist. So Kylie, who's a 34-year-old mother of 2 boys, she's come to see you for an acute episode of low back pain, which began a day ago. There was no clear mechanism, but Kylie reported that her son Harry had been unwell and she had been lifting him in and out of the cot more recently. Her pain is severe and it's associated with muscle spasm that prevents Kylie from standing straight. The pain awakens Kylie from her sleep. Her main concern is that she's done something serious to her back and that she won't be able to lift her 1-year-old. The father also has a persistent back problem. So that, if you're a listener that works in primary care, hopefully is a typical scenario that you might have seen many times. I understand there might be a couple of GPs tuning in as well. So here is perhaps a scenario relevant to GPs. So Steve is a 57-year-old builder. He has a number of other health issues. He's had low back pain for the past 20 years. He's got painful knee OA as well and uncontrolled hypertension. And he's overweight and his back pain increased recently. He believes the pain's caused by crushed discs in his back and that there isn't much that can be done about it. He's come to see for pain relief and he feels that NSAIDs or anti-inflammatory medications don't work for him and that they upset his stomach, and that the only relief he's gotten is from an old prescription that he found in his bathroom cupboard. And for the past week, he's been taking 2 endone or oxycodone every 4 hours and report that that's the only thing that's given him relief. And he's run out of that now, so he's seeing you for something else. So if you can, I'd like you to keep those 2 case studies in your mind when we go through the evidence now on diagnosis and management of people like this. So obviously the first thing that you do when someone like Kylie or Steve comes and sees you in primary care is to take a history and physical examination and try and triage the problem into one of 3 categories, which you would, I'm sure, all be familiar with. This is a bit of a busy slide, but I'm going to spend a bit of time on it and I'm going to come back to it a few times. So this is a clinical pathway that's based on the latest guidelines for people with low back pain. It's from a paper I wrote last year that was published in the Canadian Medical Association Journal. And what it did was combined the recommendations from 2 major international guidelines that were published last year. That was the NICE guideline from the UK and the American College of Physicians guideline published in the US. And so what I did was I reviewed the literature and I reviewed the work in those 2 guidelines and combined them into a clinical pathway, which is what you see on your screen now. And I'm going to go through it gradually, starting with determining whether someone has a serious cause for their low back pain. So this is a major concern among clinicians, the sort of thing that you never want to miss in your clinical career, and that should probably be at the forefront of your mind with anyone who comes to see you with low back pain is, does this person have something serious that's causing the pain? So on the pathway here, you can see there's a step here where you'd like to exclude non-spinal causes. The word exclude maybe not be ideal when I go through to talk about things like red flag in the next few slides. Exclude is maybe not the ideal term there because it's actually very hard to exclude these causes. But nevertheless, you should be aware that back pain can be caused by things going on outside of the musculoskeletal system and that you should have your ears pricked for unusual symptoms. And that's really the sort of thing that undergraduate teaching is going for at the moment, is to enhance the student's ability to detect odd symptoms or things that aren't just back pain. So a good rule of thumb is that if someone has pure back pain and nothing else going on, then that's probably a good sign to continue on with your management plan. But then when something else odd is going on, like urinary symptoms or other strange symptoms like feeling dizzy or short of breath or systemically unwell, then maybe you need to start thinking, does this person have something that's going on outside of their lower back area? So, of course, back pain can be caused by odd, rare conditions, and it can also be caused by specific conditions in the spine, some of which are very serious and some of which are not as serious. So I'm going to spend some time on what clinicians should be doing to detect people with a risk of these issues. So the way we detect whether someone has features of specific pathologies, we use these questions called red flags. There's been some confusion over the terminology of red flags because some people will use the term red flag to refer to the condition, whereas it's more accurately used to describe the clinical features that could increase your suspicion that a person has a serious condition causing their back pain. And I'm going to spend the next few slides just discussing some of the evidence on red flags for low back pain. There are three things I'd like you to remember about red flags for back pain, and I'll go through these one by one. The first is that serious causes of low back pain are very rare. So although you should be vigilant for these conditions, you should also have some idea in your mind of what the probability is that a person who has come to see you with low back pain has something serious causing their back pain. The second thing I'd like you to take home is that most of the red flag questions we have, and there are a lot of them, have poor or untested accuracy. And the third thing I'm going to go through and I'd like you to take home is that imaging everyone who has a red flag will cause overdiagnosis. So the first one, serious causes of low back pain are very rare. So the best data we have on the probability that someone will have a serious cause of their low back pain, or the prevalence of serious conditions causing acute low back pain, is from a Sydney primary care sample of 1,200 patients. So this was published back in 2009. And what they found was that of those 1,200 patients with acute low back pain who presented to primary care, there were only 11 confirmed cases of serious pathologies. That's less than 1%. And that's a good figure for you to keep in your mind when someone sees you in Sydney for acute low back pain in primary care. The likelihood that they have something serious causing their pain before asking any questions is 1%. That's a good rule of thumb. So in that sample, 8 people had fracture. 1 had cauda equina syndrome, which is where there's compression of the lower part of the spinal cord impacting on bladder and bowel issues, and 2 had inflammatory arthropathies. Interestingly, even though less than 1% had serious pathology, of those 1,200 people asked red flag questions, at least 80% had a positive red flag. So hopefully that highlights some of the problems and the limitations of red flags. If 80% had 1 red flag, but only 1% had a serious problem. And to follow up on that, what we know from diagnostic test accuracy studies is that most red flags have poor or untested accuracy. So this has been the subject of a lot of debate over the last few years from our group and from others. This systematic review in pain found that most red flags for malignancy in low back pain lacked empirical support. This was an interesting paper published this year. This was data from the United States in 10,000 patients with low back pain. It was a retrospective study, so they went back and looked at 10,000 people who presented to a spine centre. So these were people with complicated back pain, not primary care. And they went back through people's files and they looked at, of those 10,000 people, how many had serious pathology, and of those people, how many had positive red flags. And what they concluded that was, while there were a few red flags that could increase the likelihood that someone would have a serious condition causing their back, they also noted that the lack of red flags. So if someone has no red flags at all, doesn't necessarily reduce their probability of having a serious problem. So I'll come back to that point later, but that's the take-home message, is that red flags can increase the probability that someone has a serious issue, but just because they have no red flags doesn't necessarily rule it out. And that's a really important clinical message to take. In fact, that data from that study found that 64% of people with a malignancy causing their low back pain had no red flags at all. There's been more debate and more and more. So rather than go through all of the red flags, which would take me an hour just on its own, I'm going to focus on the informative red flags that we know of. So there are 3 for fracture and 1 for malignancy. So as I discussed previously, I'll get my cursor happening again here. If someone walks in to see you with low back pain, they've got about a 1% chance that that back pain is caused by a fracture before you ask them any questions. If you ask them if they've been taking corticosteroids for some time, for example, prednisone for the last 6 months, the probability that that person's back pain is caused by a fracture goes up to 33%. So that person now has a 1 in 3 chance that they have a fracture. It's actually more informative to have a combination of flags. So 3 flags or more. So if someone is female, if they're over 70, they've had trauma and they've been taking steroids, their probability of having a fracture goes from 1% up to 90%. And this is the confidence range. So it could be anywhere from 1 in 3 to 1 in 1. So it really, that's an informative clinical test for fracture. Those 3 or 4 red flags. In the emergency setting, the prevalence of fracture is slightly higher, unsurprisingly, because there's more trauma presenting to emergency, or there's lots of non-specific back pain as well. So baseline risk when someone walks into A&E is 5% for a fracture, but if they have a contusion or an abrasion on their back, that goes up to 62%. So again, we would call that an informative red flag for people presenting to the emergency department. There aren't as many informative red flags for detecting cancer in people with back pain. So the only one is history of cancer. So before you ask people anything, they have a 0.5% chance of having cancer causing their back pain, very low. And then if they have a history of cancer, it goes up to 1 in 3. But it still doesn't go up to 90 or 100. So a history of cancer, we would say it's informative, but it's not necessarily a reason to send people off for immediate testing straight away. The third point about red flags I wanted to make was that if you're uncertain, imaging everyone just to be sure will cause problems. And I'm sure most of you will be aware of why that is, and that's because the odds of finding some abnormality in people with no back pain whatsoever are very high. So as these tests become more sensitive, they get better at detecting normal changes to the spine that may look nasty on a report but have nothing to do with back pain. So these are data from a fairly famous systematic review on the prevalence of abnormalities, what some would call abnormalities, others would just call normal age-related changes in people without back pain. So I'll get my cursor going again and focus in on the 40-year-olds, because that's sort of the age bracket I'm heading rapidly towards. So in my back, there's in 100 people like me, 68 would have disc degeneration, 54 would have disc signal loss, 1 in 2 people with my characteristics would have a disc bulge, 1 in 3 would have a disc protrusion, 1 in 10 would have a spondylolisthesis. So it's very likely that you will find something on a scan that may or may not have anything to do with the person's pain and may have consequences for them down the track. I won't spend too much time on this because we're going to move on to management, but this is what's called a fact box, which is something that people at Cambridge University use to communicate the benefits and harms of having a screening test or a diagnostic test. So what they like to do is they like to present the benefits of having the test in people who've had the scan and who haven't had the scan. So I'll get my cursor going. So on the top half of this panel, we have the benefits in people with and without the scan, and at the bottom we have the harms with and without the scan. On the left, these are the numbers for people who didn't have a scan, and these are the numbers on the right for people who did have a scan. So just very briefly, if for 100 people given a scan, this is for people without red flags, if 100 people were given a scan, 46 people would recover with the scan. If they didn't have the scan, 57 would recover. So recovery is better in people who don't have the scan. So these are data from systematic reviews of randomized trials of imaging versus no imaging. So the benefit is actually in favor of not having a scan. And then when we go down to harms, those who do have a scan have all these harms. So 68 out of 100 will get a false alarm. 1 might have unnecessary surgery, and 10 will be more worried about their back. Whereas the harms of not having the scan are negligible. So it's one way of trying to communicate the benefits and harms of having imaging that we're playing with. Personally, I think this is a little too complicated for a lot of patients, and some might really engage with the numbers, others might not. So we're testing different ways of presenting this information to patients so that they can make an informed decision about their care and about whether to have imaging. But that's, watch this space. So in terms of red flags, the take-home messages there are to interpret the answers to red flag questions with caution, to use clusters of features because they're going to be more informative than single features for identifying people who might have serious pathology or specific pathology. And also remember that the absence of red flags does not necessarily rule out specific pathology, so it's worthwhile being vigilant. In those who do have 1 red flag or maybe even 2, watchful waiting is probably a more wise option than immediate testing for most, in the vast majority of people who present to primary care. Notable exceptions for that would be people who you suspect may have an infection, or people who you suspect might have cauda equina syndrome. They need to be referred off immediately. But for many others, watchful waiting would be quite satisfactory. So if we refer back to our case studies, Kylie had 1 red flag, so she had night pain. But on its own, that red flag is not informative enough to warrant further investigation. And Steve didn't have any alerting features that would indicate serious pathology. Okay, so moving on to the next. So we've gone through the smallest category of causes of low back pain. If we move on to radicular pain, I'm going to go over this fairly quickly because I'm just conscious of the time. 5 to 10% of cases who present to primary care will have a specific cause of the pain that can be identifiable, and they will have neurological signs. So you detect this with a history and physical examination, and no imaging is required. On the right-hand side of this slide is a neat, quick way of doing a neurological examination that may be different to what many were taught at physio school, which I found very useful in the clinic, and contains shortcuts to doing a quick neurological examination that allows you to determine whether someone might have a radiculopathy or not. I'm not going to spend too much time on radiculopathy tonight, so we can move on to the largest category, which I want to spend the remainder of the webinar on. And neither of our case studies had neurological issues. Just as a side note though, so the most common cause of a neurological problem with back pain is a disc herniation. This is an image from the New England Journal that was published a couple of years ago. On the left-hand side of your screen is an MRI of someone who's a 29-year-old woman who presented with leg pain and paresthesia to primary care and had this MRI and found that there was a disc herniation L4-5 impinging on the cecal sac and the lower lumbar nerve roots. And the interesting thing about this is if we look at 5 months later, so this woman had conservative care and there was complete resolution of that disc herniation 5 months later. And this was an image that I had on my clinic wall towards the end, and I found it really powerful to communicate to patients who are worried that if they're diagnosed with a neurological compromise, that this is a catastrophic thing that will happen, that will last forever, and that's not necessarily true. So this sort of imagery could be very reassuring to people who are given the diagnosis of lumbar radiculopathy. So I just wanted to put that in there. Okay, so the third and by far most common category, and I can hear a communal groan from the clinical community, is non-specific low back pain. And the groan is with that term because I know so many people hate it. So I'm sorry about that, but it's really just a descriptive term to describe these cases of low back pain which aren't these two categories, and where we haven't got any valid tests at the moment to identify a specific cause. So is that the best we can do? Is non-specific back pain really the best we can do? Well, at the moment, it sort of is. We can further classify non-specific low back pain according to its duration and prognosis, but in terms of diagnosing the specific anatomical structure that's causing a person's pain, we can't do that in a valid and reliable way, and there's no evidence that doing so can improve patient outcomes. So hence the recommendation for the term non-specific low back pain. And both of our case studies would be classified as having non-specific low back pain. So although we may not be able to give them a diagnostic label, we might be able to give them a bit more information that's much more satisfactory than just telling them they have non-specific low back pain, which I don't think any clinician has ever told a patient. But what can we tell the patient? At the moment, there are recommendations to use prognostic tools to describe a person's pain and to help make decisions or to complete the diagnostic process. So once you've gotten down to the point where you think, okay, this person has non-specific low back pain, now the guidelines suggest you could further categorize that person as having a good prognosis or a poor prognosis. There are a few ways you can do this. The most common way around the globe is to use the StartBack tool, which was developed in the UK and validated in the UK. It hasn't been validated in Australia yet, which is a limitation of using that tool. There's another tool that's available in Australia called the MyBack tool, which actually I developed as part of my PhD, and we're still going through some testing of that tool, and I was going to give you a quick demonstration of that now. So I'm going to switch over to screen sharing now, Jeff, if you can help me. Just bear with me, folks. I'm just going to bring up a demonstration of the tool in my browser. Okay. So I'm hoping all of you can see my screen now. Jeff, just yell out if that's not working at your end, but I'll assume that it is. So this is the MyBack self-assessment tool. It's a prognostic tool for people with back pain. People who have back pain can fill it out themselves, or as a clinician you can sit down with a patient and do it with them. So let's do it for Kylie. So there's a brief blurb. I'll just skip through that. There's some screening questions for pathology. I'm going to skip through that. And it screens to make sure that this person has acute low back pain because it's only appropriate for acute back pain. So Kylie's had her pain for 2 days, so I'll put that in there and screened for red flags. Well, I've asked the red flag questions. And now we have the questions which are prognostic questions. So some people will call these yellow flags or psychosocial risk factors. So this is a way of putting them all together to give you a summary result of what a person's prognosis is. So for Kylie, she had severe pain. There's 5 questions. These have all been shown to be predictive of outcome. She doesn't have leg pain. Kylie's problem isn't a workers' compensation issue. She didn't report any depression when asked this question, but she did have a higher perceived risk that the pain would become persistent because of her father's history. And then we can calculate risk, and it goes into a fancy algorithm, and it can tell you reasonably precisely what the odds are of you recovering at 3 months. So you can present it in a few different ways. There's a slider at the top here. I haven't got my cursor, but at the top you've got a judgment of prognosis and an explanation of what the odds are compared to the average person, and the risk information presented in a few different ways. And it's really just a way of explaining to the person what their prognosis is in a data-driven way rather than just in a throwaway line kind of way. And there's more information down the bottom that you can use to explain the issue. This is taken from my work on explain pain in my PhD with Lorimer Mosley, who was my supervisor. So we did a lot on explaining the neurophysiology of pain, and there's information on there to help the patient make a decision on what they want to do next. And you can even print their risk information. So that's a tool that's available now, and you can access that via the link that I showed you, and I'll come back to my slides now, but I just wanted to show you that as something that you could potentially do. I'm just going to turn screen sharing off and back to my slides. So yeah, so there are tools available to be able to take non-specific back pain into a little bit more detail and judge a person's psychosocial situation and the impact that might have on their recovery, and then talk to them about it and talk to them about what their treatment options are. And we think that would be a really useful way for clinicians to go, and it's currently recommended in guidelines. You wouldn't use that tool I just showed you for Steve because he has persistent low back pain, and we haven't validated the tool in that patient population just yet. Okay, so I'm approaching the 40-minute mark. I know this talk was about management as well, but it's focused a lot on diagnosis. But management, hopefully we can get through this reasonably quickly. A key aspect is obviously advice and reassurance for anyone who doesn't have the signs of serious disease. So that's a key component. If you have radiculopathy or non-specific low back pain, there are questions that still arise about what the best explanation is, and I did work on this on my PhD. So there's a strong belief that using threatening language and diagnostic labels is very unhelpful to people with low back pain. For example, this screenshot at the bottom here is a tweet that circulated recently about using language that could be harmful and potential alternatives, which is a wonderful idea, but we still don't have hard data on the effects of these labels that you could put on non-specific low back pain. So that's a keen research area of mine. But the clinical consensus is don't scare people. Guidelines tell you to reassure patients that there's no serious condition, that the prognosis is good. And one interesting thing about the prognosis is good is that rather than just telling everyone that, you can actually find out whether their prognosis is good or not, and maybe just tell the people who do have a good prognosis that they're going to go well, and don't lie to the people who do have a poor prognosis. And I think that's a neat thing about the tool that I just showed you, is you can be a bit more specific. The obligatory advice to remain active, but we still don't know the best way to do that and how to engage people in that advice. But it's probably a necessary part. Yeah, I'm just seeing, just bear with me for a sec, folks. Yep, okay, and I would add a few bits of information on that slide in terms of the need for imaging and the need for pain medicines. I would include that in my explanation. I've given you a couple of scripts here, and there are going to be PDFs available, and I can see on the left here that people want to see the case studies again. So I'm sorry I can't go back to those immediately now. due to time, but people often ask me, how would you explain this to the patient without using the term non-specific low back pain. So I've given you two explanations that I'm not going to go through in detail, so I can give you a chance to ask questions, but you can go back and have a look at the PDFs perhaps at the end of the talk. In short, though, I use terms to validate the person's pain, but to not make it sound like a permanent injury, and to raise the possibility that there are lots of things that could be done to manage it. I would always do that to give them, hope about what they could do next. In terms of what they could do next, there's a bit of a myth out there that there are no real treatments for back pain or no evidence-based treatments, but actually there are lots of evidence-based treatments, which are summarised at the bottom of our clinical pathway, which we've gotten to now. The first thing I want you to notice about this slide is about these bottom boxes is the number of options that are available for people with radicular pain. It's a very small box, so there's not much in the way of evidence-based options for people with radicular pain. So there's a lot of work we need to do there to figure out the best way to help those people. A few more options available for people with acute, non-specific back pain, so they're people with pain for less than 12 weeks. And you'll see that the biggest box is for persistent, non-specific low back pain, so there's lots of treatment options for people with persistent low back pain that you could discuss with your patient and gauge their preferences. Here's a summary of the evidence for treatments for people with acute low back pain. Two things to note from this slide. I'm not going to take you through all of it. So these are the effect sizes from systematic reviews of randomized trials. Two things to note. First is that there are no trials on opioids for acute low back pain. So it would be unwise to prescribe opioids to people with acute low back pain as a first-line approach, and it's certainly not recommended. The other thing that some of the physios listening in might be surprised to see is that there's high-quality evidence that exercise, compared to no treatment or sham or placebo, there's no effect of exercise compared to those conservative options or sham. There are the take-home messages there. Again, options for people with persistent low back pain. So this would be options for Steve. Lots more to choose from. Take-home messages from this slide are that the effect sizes are uniformly small. So these are in the range of about 2 points to 10 points on a 100-point scale, 100-point pain scale. So these treatments reduce pain by about 2 points to 12 points on a 100-point scale compared to placebo or no treatment or control. So they're not large treatment effects, which is something that should be communicated to patients. And a side note here that although these radiofrequency denervations were included in guidelines, there's subsequently been a nice placebo-controlled trial that has suggested that those treatments are ineffective, so they probably won't be in future guidelines. Here's a pictorial summary of the options for guideline-recommended therapies for our case studies. So Kylie, remember, had acute back pain just started. She was worried about it, and she had young children that she needed help to get back to, and so we said, obviously, for both Steve and Kylie, advice and reassurance is key, and then these are the additional treatments. So there's heat pack, and on the left-hand side, we've got heat packs, acupuncture, massage, and spinal manipulation are all endorsed by current guidelines for acute low back pain. So they're the things you could propose to Kylie that she could choose from to manage her pain in the short term. On the right, Steve has a few more things to choose from, including Tai Chi, exercise, mindfulness-based stress reduction is up the top. These are all Army recruits doing this because that seemed to be the freely available Google images. Yoga, cognitive behavioral therapy, and physical modalities such as acupuncture and core tummy exercises. So the take-home message there is that there are things to choose from, and that the challenge is discussing these within the consultation and engaging with the patient to decide on what their preferences are. So for the case studies, when we told Kylie about her prognosis and the benefits and harms of available treatments, she opted for a course of manual therapy combined with self-management using heat packs, and to return for review in 1 week. Steve wasn't interested in any of that wishy-washy complementary stuff, the yoga and the Tai Chi and all that. But he was open to an exercise program, but also worried that it would aggravate the pain and that it would cost money. So it's currently recommended to start with the non-pharmacologic treatments first. That's a key recommendation in recent guidelines, and only use the medicines as the backup. And these are the medicines that are recommended for acute and persistent low back pain. Because we've got majority physios listening, I might have to skip forward because I'm sorry I'm running out of time. Take-home message for medicines is that if you do need to prescribe a medicine, you do so at the lowest dose for the shortest possible time. And if someone has persistent back pain, it shouldn't be opioids. So here is what happened with the medicines for Kylie and Steve. So Kylie tried an NSAID, that was guideline concordant, and Steve discussed tapering the opioids with his GP, which I might let you guys read at a later stage. And there are more resources on tapering opioids, which is a challenging thing to do, but there's a nice CDC guideline available for you to read and to use with your patients who are having trouble with opioids. Now there's 15 minutes left, so I'm thinking of moving ahead now. This last slide was talking about how to stratify according to risk, so you might want to offer them more in terms of choosing which therapy is best, or to mention to your patient, you could use their risk profile. So maybe for people with persistent low back pain, the low risk people with persistent low back pain, perhaps you wouldn't offer them a course of 12 weeks of CBT, but maybe an exercise program or some manual therapy in the short term could help. So you could use prognostic risk to guide your decision making, and of course patient preferences are key. I'm going to skip over prevention so you can look over those in your own time, so we have time for questions. And there's also some myths and misconceptions which I'm certain all of you would know about. I'll click through them there, and I'll refer you to a fantastic article from my colleague Mary O'Keefe, who's very famous on Twitter and is working with us now in our research group, and she's written a wonderful article on the common myths and misconceptions of back pain. And feedback's been that a lot of patients enjoy reading this article as well, so there's another resource for you. There is some further reading, and I'm sorry that we had to rush through the management, but hopefully you found the diagnostic information interesting and new, and you can work on shared decisions with those guideline concordant management options after reading through those again, because there's a bit to take in. So thank you very much again for joining me, and I'd be very happy to take any questions. There might be a couple or maybe not, but I'll just have a look at what Jeff has for me now. And Jen.
Yeah, hello Adrian, I'm back on air.
G'day.
And look, thanks very much for a very comprehensive presentation and so on. I'd urge people to type in their questions now. We've got about 10 minutes left before we need to finish. I've got a couple of questions, Adrian, because you mentioned about certainly the advice for people with acute back pain is to remain active, but you made a comment that we're not exactly sure what that is. And then you also showed that sort of the evidence about exercise and the fact that there's little research finds that sort of demonstrate there's little effect given versus no treatment or sham treatment. So can you just elaborate a little bit more about that sort of the remaining active, the exercise, what you would recommend best? I mean, you had the photo of Tai Chi and so on. Further comments there?
It's a great question, Jen, and one we're still trying to grapple with because it's such a non-specific recommendation to stay active. And active, the word active for different people will mean very different things. So I think the first thing I would say is when you're providing advice to stay active, you need to be very specific about what you mean. Active may not mean doing exercise necessarily, because the evidence is that those interventions that were shown to have no effect, they included programs of McKenzie exercises, so repeated movements in a particular direction. Tummy exercises were included there, and general aerobic exercise. So when you do that type of exercise, it doesn't seem to help. But what we do know is that if you rest in bed, that can be harmful. So we need to find a middle ground. So yeah, it would be about discussing with the patient, what they're having the most trouble with, and giving very specific advice about how they can remain active given the limitations that they've got. So, for example, Kylie couldn't even stand straight. So just saying to her, just stay active, and she was worried that she couldn't, lift her child. Just stay active would be unsatisfactory for Kylie. You'd have to be very specific about giving her strategies to keep her back moving as best she can, and to gradually return to everything as normal. But that may not include systematic planned exercise. I'm not sure if that answers your question.
Yes, and also it was interesting just with Steve, and as you sort of said, his concern about the pain he might experience if he was to engage in exercise as part of the
Yes.
treatment and management. So again, reassurance there.
Absolutely, yeah, and that's a major contradiction there, because so for persistent back pain, we do have high quality evidence that exercise can be helpful. But in those patients, many would believe that the pain that they're feeling when they're doing exercise is a signal of damage, and so of course they're not going to want to engage in exercise. And if that's the case, then that person would need thorough education about why exercise is thought to help with persistent pain and why it's safe for them to do so. But yeah, that's a really stark demonstration of why we do need to. Some people get a bit annoyed by separating people with acute and persistent pain. They say pain is pain, but when you have the evidence base that says one treatment works for one group and it doesn't work for another, that's where it's really important to base what you're doing on the person's clinical presentation. So for acute, the exercise is not important. For people with persistent pain, it's very important, and you need to have strategies to be able to engage people in that.
We have a question here, Adrian. Is there evidence regarding the time frame manual therapy would be recommended for persistent pain?
Yeah, that's a great question. So no, there's not a specific guide to how much manual therapy you should provide, and certainly was the question for persistent back pain or for any back pain?
Yeah, for persistent back pain.
Yeah, so obviously there's a concern with persistent back pain with overuse of passive therapies. That's criticised out in the clinical community, and certainly the recommendations lately are to promote self-management. So that would be the focus. But in terms of how much manual therapy you should provide, no, there's no strict guidance. Most of the trials in people with persistent back pain provide between 2 and I think up to 6 weeks of manual therapy. But I think, yeah, as long as these therapies are provided in addition to self-management, I think using manual therapy as a bit of pain relief would be perfectly concordant with guidelines. But yeah, you'd have to use your judgment on that.
Another question, what would you recommend for someone who has had an acute exacerbation of chronic back pain which occurred by simply rolling over in bed? Also, the person's unable to take NSAIDs.
Yeah, so acute exacerbation of chronic pain and can't take NSAIDs. So a little bit like Steve, but perhaps more irritable, so really triggered very easily overnight. So yeah, obviously there are for the short term, was it medication options the person wanted to know about, or non-pharmacologic options?
I suppose either. It's not actually specified, but
let's go back to better for me to answer that if we go back to the medication options and non-pharmacologic for persistent back pain. I'll get a clearer slide for you. Can you still see this, Jen? Me clicking through the slides?
Yep.
Okay. Yeah, so this is the quandary that people will have with persistent low back pain. So if you see the bottom right, the only pharmacologic option that's offered for people with chronic low back pain is NSAIDs. So this speaks to the listeners' point. You know, what do you do if someone can't take NSAIDs? And that was the case for Steve. And the current recommendation would be you would try non-pharmacologic options. So that would be any of the physical therapies. So that includes heat, massage, and spinal manipulation, even acupuncture, which has dubious evidence, but it still seemed to sneak into the guidelines. But yeah, if someone has an acute exacerbation of chronic back pain, there are limited pharmacologic options, especially if they can't take NSAIDs. So you'd be recommending perhaps some physical therapies to start with, and if that wasn't effective, you could step up to more comprehensive programs that could include, you know, psychological therapies or a combination of the two. You could do that based on their prognosis.
Yep, sure. We've got a couple of questions coming in, and I'll just remind people if Adrian has kindly offered to respond briefly in writing to any questions that don't get answered before we finish up, and they will be provided with the follow-up resources after tonight's webinar. Another question, and a bit of a dilemma here, people present to an ED department with an acute exacerbation of their chronic pain. Often they're on meds that are not recommended, and unable to take NSAIDs. Is there anything we can refer to them in the way of an article for them to read or other material?
Yeah, consumer material. That's something that you might have to leave with me. I don't have an immediate answer to that.
I think that's fair enough, Adrian.
Yeah.
That is a very tricky situation, but maybe
it's a tricky one, and it's very common, and we are working on those materials at the moment. So we're working on trying to develop materials for patients and clinicians that are grappling with that decision in the ED. How do you get someone out of the emergency department within your 4 hours when they're completely incapacitated by pain, and you can't give them strong medications because it's not guideline concordant? What do you do? That's a really big question that we need to do some more research on, but leave it with me, and if I do find patient resources, I can certainly pass them on.
Yeah, actually, Debbie has just typed in a message saying the ACI has consumer information on low back pain. So if we can locate that, we can certainly provide a link in our follow-up resources.
Yep, they have a nice.
Yep, weight loss through use of exercise wasn't included as a suggestion for decreasing lower back pain. So weight loss.
Sorry, Jen, can you repeat that one?
Weight loss through the use of exercise. You didn't mention it as a suggestion for decreasing lower back pain?
No. That said, so the evidence on the link between obesity and back pain is not very strong. That said, you know, if you view back pain in a biopsychosocial framework, these other, you know, general health factors are going to be important. Whether there's a causal link between obesity and back pain, we don't know that yet, but certainly, you know, we know exercise can help with pain. We know exercise can reduce obesity, so why not? The trick is to do it in a very thoughtful way that's probably combined with education, because to be able to do that in someone like Steve, who is obese and with knee OA, that takes a lot of skill, but certainly it would be it would fit with what the evidence is on what we should be doing with people with persistent back pain and other health issues.
And just quickly squeezing one last one, is it okay to take pain meds prior to an exercise plan? or will NSAIDs, paracetamol reduce adaptations or recovery time? Taking some pain medication, I suppose,
to facilitate exercise.
Yeah.
I think a lot of physios would do that as a strategy to facilitate exercise. And again, there will be patients that simply cannot function without some help. So a lot of people think that the recommendations to just start with non-pharmacologic therapy and exercises and just do that with no medication whatsoever, people think that might be a bit naive. And it certainly seems like it's a knee-jerk response to the opioid problem in the States, so that's where they've reversed. So previously it was start with medication, then move on to these physical therapies, but now they're saying do the physical therapies first, don't do the medicines first. So to answer the question, it would be no, I probably wouldn't start with medications if you can avoid it, because all of these medications, including NSAIDs, have risks. And I detail that more in my paper that you can see on the screen there if you want to read a bit more about that.
Great. Listen, we're right on just a tick over 8 o'clock, so we will finish up. Adrian,
Okay.
Thank you so much for a very comprehensive presentation this evening, and also your responses to those questions that were posed. I'd
My
like
pleasure.
to thank everyone who has joined the webinar tonight, and ask if you could quickly just respond to our questions, our feedback questions on the screen. Thanks again, Adrian. Thanks again, everyone. Remember our next webinar, which will be scheduled for late August and is on the important topic of the diagnosis and management of adhesive capsulitis, another very important issue. So, look, thanks, everyone, and I bid you all a good night.
Thanks, everyone.